Since 2 days we had been listening about what is the difference between morals and ethics. And even as I was going through for the simple definition of moral and ethics, the simple definition says morals are a set of beliefs, rules and regulations that an individual has or the society puts on, which guides his or her behavior. Whereas ethics is something what we consider as values and standards that govern human behavior. At the same time, it also implies for others. Our behavior has an implication for others. Keeping this as a background, we have been focusing on the title that ethical consideration in community engagement for health. Particularly today, we'll be discussing on this aspect of from practice, how it can be used or applied in education, and then through ethical education, how it can be used in the workplaces that we are engaged with. And as we are aware, ethics is not optional, it is imperative, it is foundational. It should not be in the periphery, it should be in the center. Keeping this as a background, I just wanted to invite and welcome each one of you for this panel discussion and presentation. At the outset, I want to thank each one of you for taking interest in this regard and stepping in this hall for a fruitful, productive discussion. As we have a presenter on this topic, measuring the intersection of structural discrimination, non-compliance, and implicit attitudes in healthcare, we have Jacob Dahlke from Nebraska, USA, will be presenting. He has 15 minutes presentation, and after which we'll be having 5 minutes for Q&A. Kindly reserve your question and answer for the end of the session. Let us put our hands together and welcome Jacob Dahlke from USA to present on the topic, measuring the intersection of structural discrimination, non-compliance, and implicit attitudes. Welcome, over to you, Jacob Dahlke.
With regards to my slides, I think there's an important conversation to have at the end of my presentation. I'm going to skip some slides or go very quickly through some. If you are interested, I don't know if the organizers are planning to share the presentations with everyone. If not, I'm happy to share them with you. So if you would like to get them, give me your email address and I'm happy to send them. So with that, I want to make sure at an international conference, everyone sees I'm from the middle of the country in the United States. I work for Nebraska Medicine, which is a health system in the largest city in Nebraska. We have about 1 million people. We are a level 1 trauma center, so what that means is we can handle any type of intervention that is in the region, whether it's surgeries, transplants, every type of crisis. We have 2 different campuses and have over 550 beds there. And the academic side of the health system, University of Nebraska Medical Center, does over $250 million in research every year. So what I would like to do, again, I'm gonna skip through some of these questions, but I think it's important to sort of set the stage for the history of structural discrimination in the United States healthcare system, so that I can talk a little bit about my current research. And then I think the important piece here is how do we engage as a community, or as a health system, how do we engage with our community to make things better? So in terms of this background, I think if anyone was at the plenary session just now, we talked a lot about the foundations of human dignity and things like that. I think there's also a fundamental component which is bias, right? So our automatic reaction to being in certain situations, it is a biological response that we can sometimes not control. And if we don't pause and think, why are we doing this? Why am I having this type of reaction? And should it be the right reaction in this situation, or should I do something differently? I like to think of that as an overall human condition. And that's something that we need to address and think about and learn from. But in terms of the United States, we have a national system, and really what we have is a history of medical discrimination and medical racism. And so I think in order to talk about that, I think it's important to talk about some of the definitions of what I'm talking about when I talk about structural racism. So in American society, this is a very dominant force, right? This is a political construct. This is a social construct. There's no biology behind any of this. And it's something that affects individuals at every part of their life. So we're not only talking about racism that exists in healthcare. Those same people that experience that racism in healthcare also experience it in education. They also experience it in housing. They experience it in employment. And so they experience it in all sorts of different parts of their world. When I refer to health disparity, this is a gap in what we would want to see based on what we currently have. So a health difference, this is what we would want to see for a health outcome, but we are not getting that. And when we are not getting that, we are usually getting it for a particular population of people, again, who are being discriminated against in other places outside of healthcare, but it ends up affecting their health, and so we have this disparity of care. Health equity refers to that ideal that I just mentioned, right? This is the ideal situation in which everyone has a fair and just opportunity to not get everything that they want, but that they get access to the care that they need. And because I might need different types of health care than you, we may get different levels of health care, but we are getting what we need. And so it's the ideal version of this. If everyone were to get that, that would be what I refer to as health equity. It's the ideal. And the purpose of my study was to study this concept of non-compliance, which is a description that healthcare professionals often use to describe patients who are not doing what the physicians or the clinicians think that the patient should be doing, right? And sometimes they are doing it because there was an agreement between the patient and the clinician to do certain things, take a certain medication, come to an appointment, what have you, and then that did not happen. And so the physician or the clinician might refer to that patient as non-compliant as a result of that. Usually without consideration as to the reasons why the person did not take the medication or why the person did not show up. It is simply a determination, it's a conclusion that we make about the person. And my theory is that there are problems to this practice and that we should change the way that we do it. I'm going to skip over this for the sake of time, but the takeaway here is that the history of the medical profession in the United States very closely aligns historically with post-Civil War society in the United States and the continuation of structural racism, the continuation of trying to discriminate against African American individuals in the United States. That was historically aligned with the goals of physicians in the United States trying to legitimize their practices and be taken more seriously as a profession, and their interest in perpetuating the systemic racism that was taking place outside of healthcare. And so, in a sense, they sort of joined forces and worked on things together. All of these things which have been disproven as being problematic or morally wrong even. But I don't think that the American healthcare system is quite reconciled with this reality. And so we continue to have problems like, in my view, the practice of saying things like non-compliant. And so, again, I'm going to skip this for the sake of time. So what I want to talk about then is my current research. I started with a very basic question, right? So do clinicians describe patients as non-compliant? Remember this definition from before. Do they describe patients as non-compliant at different rates according to the patient's race? And so what I did was I looked at patients' medical records. We have an electronic medical records system in the United States, or at my health system. And so I did a query and did a search in their medical records for mostly two things. I distributed, or I broke the two groups according to race, and then I searched for how often we found these terms in their medical records to compare whether we are treating patients equally when it comes to describing them as compliant or non-compliant. again, for the sake of time, I'm going to skip this, but there's a common practice in my region, at least, where we use two different words. We use this word adherence similarly, so I treated it in my searches similarly as well. Again, I want to get more to the conclusions in the discussion, so these are the methods that I took. And one of the other things that I did too was I noticed we were not just, I am interested in non-compliance as a term, right? Because that's a description that you are being a bad patient. You're not doing what you're supposed to be doing. But I was also seeing references to positive compliance. So the patient is being compliant with their medications. So I wanted to count it all, but obviously they're not the same. So I graded them according to whether I considered them positive references or negative references, but I also found neutral references. So we have guidelines and recommendations that healthcare professionals might comply with. So I want to comply with the guidelines around privacy and confidentiality. So there might be references in the medical record to that, but that does not really have anything to do with what I'm trying to study. So that was what I considered to be the unrelated, right, or a neutral term. So I had sort of a different category for these words as well. So the way that this looked, I had, again, different types of compliance. We had this positive compliance. So for example, the patient is compliant with their obstructive sleep apnea treatments, right? So that's a diagnosis that they have where they have a hard time sleeping. There are certain treatments that you can take. So the patient is compliant with that. Or they are adhering to the medication. They are taking the medications as they have been prescribed to them. So that's a positive compliance reference. We have these neutral references. So a very common one was in our emergency departments. When a patient is discharged from the emergency department, they get a bloody nose or something like that. It's a standard statement to say that the patient verbalized understanding and the ability to comply with whatever instructions they had for their bloody nose or something. It's not saying that they did it or did not do it. It's saying that they understand the concept. So again, it's not exactly what I was trying to think of, so I consider that neutral. And then we have these unrelated ones that I was telling you about as well. And then the more important thing, the more important category that I was considering were these negatives, right? The concept of, patients being extremely not compliant with the treatment program, or they report being compliant, but I don't think that that is the case, and I don't believe them as the clinician, right? So they're still being non-compliant. And so I conducted the search. I had a statistic I took, and so what I found was, if I had a total of 163 medical records for white patients, as described in their medical records, 163 patients in their medical records being described as Black or African American. And what I found was that there was overwhelmingly more references of negative non-compliance in Black patients than in the white patients. So 44% of the Black patients had negative references, 14% of the white patients had negative references. And when they were just being described as non-compliant, they were being described more often. More times they had many, many references. We're not just talking about one reference. We're talking about 15, 20, 60. I had 101 references in the medical record. So it was happening much more often as well. And again, once you reached a certain number, a certain frequency of references, white patients just didn't have any. Over 15, there were no patients that way. And so taking all of that into conclusion, Black patients in this study were 3 times more likely to be described negatively as non-compliant than white patients. And then when I counted the entire total sum of the compliance references, right? So not just the negative ones, positive, even the total neutral, unrelated ones that didn't actually have to do with their behaviors. What I also found, overwhelmingly, 50% of the white patients did not have any, and only 19%. So overwhelmingly, almost 90% of Black patients had some sort of reference. Maybe it didn't have anything to do with their behaviors, but we are simply using it more often in this population of patients than in others. So Black patients were 4 times more likely to have any kind of reference at all
positive, negative, neutral than their white patients. So for me, what's interesting or why this matters is we clearly have a difference in behaviors, how we describe these patients. I think further research is definitely necessary to understand why. I think one of my theories is that there's this component, remember bias being an overwhelming human condition. If we have physicians or clinicians who haven't taken the time to think about this, they're all very well intended, right? We have good people doing things and doing work in healthcare. But if we haven't taken the time to wonder about what our biases are, then we're not going to address them when we recognize that maybe there are some flaws in them. And so I would like to further study the clinicians and what are some of their biases. There's a really, really interesting website called Project Implicit through Harvard University. If you just go into a search engine and look for Harvard implicit bias, it will come up very easily. But it's a score, it's a test that you can take, and there are all sorts of different kinds of tests, not just about race, or not just about black versus white. You can take all sorts of tests around body type, about gender and sexism, all sorts of different tests, very well validated. It's very enlightening. I encourage you all to take it yourself as well, just again, to try to challenge what it is that I think about the world. I did collect a lot of other data in this survey, so it wasn't just connected to race. I also looked at age, gender. There's a scoring system called ADI, which is the Area Deprivation Index, which is a score of where it is that you live in a certain region and how that relates to your health risks. So the higher the score that you get, the riskier neighborhood you live in, basically. And so I studied that as well. So there's all sorts of additional data that I'd like to look at to see if there are other connections that could be made. But really my interest, I am a clinical ethicist, so I work in the hospital with physicians, with nurses, with patients. And I think we have some work to do to make sure that our policies within our institution better align with what we could be doing for our patients. And then again, as we think about how we train the next generation of clinicians, not just physicians, but nurses and social workers and therapists and everyone who encounters patients, I think there's an opportunity to encourage them to think about the words that they use and why it is that they are using them, and if perhaps there's a better way to describe what it is that we would like to think. So. In closing, the last thing I'd like to say is that, while bias is a human condition, that's something that we cannot necessarily avoid. The consequences of that, when we act on inappropriate biases, that is a choice. That is a political choice that we make. And if we don't like the consequences, then we need to choose or act or behave differently. So with that, thank you for your time, and I'm happy to take any questions or comments.
Thank you, Jacob Dahlke, for this wonderful presentation on the structural discrimination. You wonderfully brought about the political aspect of racism, and also you spoke about the 4 different kinds, where structural racism, health disparity, health equity, and non-compliance. And also you touched upon medical racism. And when you came to conclusion, it is more of a bias that is emerged in the research study, where 44% of Afro-American or the blacks who are non-compliant when it comes to white. There can be bias. And it is very interesting to know the perspective where you have researched and you have come to conclusion. It is interesting. In India, we might have not racism, but we have this poverty. We call the privileged and underprivileged. We call below poverty line. The health facilities are different for different category of people, the haves and the have-nots, or the rich or the poor. Especially when it comes to medical services, the haves will go to the private or corporate hospitals, where the have-nots will have to go to government hospital with the BPL card. And in line with that, as I was thinking, as we are in this conference, are we ethical in providing the medical services? So that's where this entire session leads us to think about it and how practically we can include this ethical education in our practice, whether we are engaging with the communities or in the medical services. I just want to applaud and congratulate you on your presentation. It was very interesting. And I also ask the co-chair to point out one or two sentences, after which the floor is open. You can ask questions to Jacob Dahlke.
Thank you, Jacob, for that sort of an insight, and then for also all of us to look within us in terms of how we are all privileged and then how do we get over those biases. But having said that, I have lived in the US for some time. So you talked about the structural determinants. So, and then you also come from the clinical practice and stuff like that. And US has a strong protocols and SOP. So in those terms, I understand that your compliance and adherence comes from the patient point of view or the patient's compliance and adherence. So, but I just want to deviate and understand for your, while you ask the details of the patient for an affirmative action in terms of the race or the religion or whatever. So how much of it is embedded in your SOP or in your protocols, and then how much of it is the clinicians oriented? Because like Alfred said, we also have something similar in terms of caste system wherein the caste census happens for an affirmative action, but it totally deviates, if I can use the word U-turn, and that helps in discrimination, more discrimination than affirmative action. So in that context, I just want you to throw light on the, from the clinician point of view, the compliance in terms of following those protocols or affirmative action and SOPs. So.
In the United States, there's a very strong policy from the federal government, states, institutions. We have policies around non-discrimination. So we have statements that say we will not discriminate based on age, sex, race, things like that. And so I have always had a problem with that because it doesn't give us guidance as to what we should do. You know, it tells us what we don't do, and as long as I don't have to do something that says, oh, I see the color of your skin, I'm not going to treat you, I'm going to treat someone else. I'm doing something that would violate that principle. It becomes problematic, I think, for us to just simply have a blanket term that says, these are the things that we are not going to do. And so I think when it comes to affirmative action, that is an attempt, however imperfect. It is an attempt to say these are the things that we are going to do. We are recognizing that our society sets apart certain people based on things that have no otherwise good reason, right? Age, sex, gender, you name it, race. And so it's an attempt to fix the problems in other parts of our society. And so I think that extends to healthcare too, right? We have all of these differences that we put on people outside of healthcare that ends up making those people sick and makes them sick in ways that I don't get sick because I live in a neighborhood that has a low risk index. So I am less likely to become sick, but we put certain people in those neighborhoods and make them sicker, and then we get mad at them when they get sick and come to the healthcare system. So I think we have to, if we're not happy with that cycle, we have to do something differently, right? Healthcare is an extension of the society that we live in. It's a consequence. It is the end, right? Everyone lives in the society until they get sick, and they stop, and because they're sick, and so they come to the hospital. They stop living in society until they get better. So it is a consequence of the society we are in. If we don't like that, we have to do it differently. And that's a choice that we make as a society.
And I'm a faculty at Azim Premji University. Thank you so much for your presentation. I have a couple of questions. One, I wanted to understand, partially this can be explained because of the inherent bias, the structural discrimination. But do you think there is also a factor of actual, non-compliance, or, they are unable to actually continue with the treatment because of the social conditions which are not so conducive for continuing the treatment? How do we look at that aspect? And second, did you also try to bring, some more nuances in terms of what is the story for, say, black women or black children, or those who are people with disability. So did you kind of try to bring that up?
Yeah, I think what you're referring to, as we refer to it in the United States, at least, maybe it's everywhere, is social drivers of health. So again, these are components of society that are not a part of healthcare. So again, the address or the neighborhood that you live in, your ability to access quality education, the ability to access healthy food, right? That's not really healthcare. That's another part of our society, but how you have access to those things does impact your health. So they are social drivers of health. And so I didn't explicitly talk about that. That does sort of speak to the health disparities and health equity and that conversation. But I didn't speak directly to it. But that's very much a factor, right? And so we know, you referenced Black mothers, we know that they have poorer or less access to health care. And so when they have they have worse outcomes when you compare them to white mothers, and we wonder why, right? So we need to do something differently before they even become pregnant, right? That's going to increase the ability to have better outcomes, which has nothing to do with health, right? So then how do we as health systems engage with our communities before people get sick? We can take care of people once they get sick, but we need to do a better job before they become patients, when they're just people.
So thank you, first of all, Jacob. I think the main thing that you mentioned was about how non-discrimination can lead to a certain kind of race blindness, right? And thank you for taking off the covers and making it explicit. My question was two questions, actually. One is, who are the ones who are adjudicating compliance, right? So what are their racial kind of context? Like, who is saying this one is compliant, this one is not compliant? And is there diversity in that? So that is one question. And then the second one is the discourse on compliance itself. We know the people who are making the discourse of compliance are coming from a certain cultural context, and they will say, okay, the white culture by default is the compliant culture, and anyone behaving differently culturally also, and that connects to like a Muslim culture or a Dalit culture in Indian context, would be by default a different non-compliant culture according to a elite upper caste culture, right? So, so the discourse of compliance itself, if there is any reflection.
No, to your first question, I did not study this specifically, but I mean, we could look at the demographics of the health system that we have. It is the majority white, and so I think there is a difference when we're talking about who it is that's doing the labeling. And to your second question, how are we thinking about this in a culturally sensitive way? I can't answer that yet. I think that's an important question for us to consider as we move forward, because again, if part of this solution is better education and more conversations with our clinicians, that has to be a part of the discussion, because we clearly have a difference in when you are not doing something, why are you not doing it, right? I think you should be doing it, but you're not doing it. Why? Maybe you can't afford the medication. Maybe you can't afford the bus to get to the appointment, right? That is not non-compliant. So we need to do a better job of understanding the reasons why and describing them in that way. We don't need to say non-compliant. We need to say they can't afford to get on the bus. That's the reason. And then we might have a solution for that. We might be able to help them out with that. So, yeah. Thank you.
Of the treatment to consider, because for compliance, like if it is just a nose bleed, maybe it's a short this thing, but if it is something long term, so automatically people tend to leave out on the treatment if it is not being very effective.
That's a good question. And how it relates to compliance. Not specifically. What I was able to find was that the more problems they had listed, they actually had more compliance, like better compliance, more positive compliance. I want to discover and research a little bit more about that, but I didn't have a lot of information. I did not study that yet about the specific interventions, but I think that's available. I think I can find those answers, but it's a very good question. Yes.
One
with the bioethics movement in USA, because USA is looked as some kind of an origin of the modern bioethics. And unlike many other countries like India, where we had research ethics as a major concern and the committees, from 1950s, you find that clinical ethics committees are almost in every, hospital institutions. So my question is, all these studies that I have seen, which is bringing out the prejudices and biases in the medicine and healthcare. Now, how is the bioethics interacting with it? And this clinical ethics committee, which are sitting at the, in the hospitals, do they act as advocates for the protection of the African Americans, the Chicanos, and other, migrant people who are there, or they are just co-opted into the system and they are not doing anything, while much of the protest is coming from outside and not from the bioethics itself. And that brings the last point is the bioethics is equally biased and racist as medicine is there?
Those are very good questions. I think the American bioethics community has been asking those same questions for the last 5 years. I think that was one of the consequences of the COVID pandemic in the United States, was we started asking ourselves, what is our role here, and how should we be improving the lives of people who are clearly discriminated against when it comes to really, really serious health situations. And so I think those are very good questions. I don't have an answer for them. I think we are struggling with how we have perhaps let things go prior to that, and we need to do better. We need to do better as bioethicists, definitely. Yeah.
We have practitioners who had been in the field for almost 15, 20 years, and we have a perspective where, as many of you also addressed by saying that it was like something top-down approach. Is it people-centered? Is it patient-oriented or centered research? And even in the yesterday's discussion, there were many points which were brought where it is almost, I want to do it, and what about the patient? Is he agreeing, or is she or he willing to participate in that? Have you oriented them? Are they with us when we do this research, all these aspects? So to answer this, or just to brainstorm on these aspects, whether we are on the same page in our research, in our practice, we have come up with this title called Ethical Consideration in Community Engagement for Health, from Practice to Education and Translation. This morning we have 4 of the panelists who have contributed to the society. They are practically doing their work. They still continue to work in the communities. We have Prahlad IM with the environmental science background, working on especially the WASH component, water, sanitation, hygiene practices, which are very crucial. We call it as social determinants of health. He had been working since 15 years with SOCHARA, and he has worked with Swachha Bharat Abhiyan, government of Karnataka, and he still continues to work on the rural and urban sanitation. Currently, he is engaged in the water and sanitation project of this HCL, which has been HCL funded project in 25 government schools and 4 urban poor localities. That is our entry point, but we work on the community health aspect of it. On behalf of all of you, I would welcome him to the panel. He'll be focusing on the funders' perspective, ethical dilemmas that come when we meet with the funders and with the community leaders when we step into the communities. Rural and urban settings are 2 different sides where it has to be dealt in its own way. The context is different. So he'll be touching upon it and sharing his experience. Second, we have Mr. Ameer Khan. He's also our SOCHARA team member. He closely works with the government of Tamil Nadu, with the team, Suresh and other team members, focusing on community action for health, closely monitoring the health activities of the government and how community and government is. This team is trying to bridge the gap between the community and the government. He has been doing wonderful work We are also the secretariat for PHM. Yeah, convener for this People's Health Movement, and he has a vast experience, and he will be sharing about his experience of community engagement in Tamil Nadu and also with the government. Third, we have Dr. Nancy, who is from this Department of Community Medicine from St. John's. She has completed her MD in Community Medicine from CMC Velo. She is a member of Institutional Ethics Committee of St. John's Medical College and Secretary of National Catholic Bioethics Forum, CCBI. She teaches MBBS and MD students and train community health workers like ASHAs and community health workers. She has both academic as well as the community experience. She'll be sharing basically about our experience of how to engage and also inculcate the ethics in our education at the same time, community engagement. We have Dr. Supriya, and she's a lecturer, assistant professor at Sydney Health Ethics, School of Public Health, Faculty of Medicine, Health at the University of Sydney. And as most of us spoke, as you were presenting from Indian perspective, she explores ethics, embodied emotions, and politics of knowledge. She also employs this critical philosophical, ethnography, and a phenomenological approach. She critically examines structural injustice in health, disrespect, and othering, the ethics of belonging and intersections of paternalism, respect, and agency. So that's where I said reserve your questions, because she'll be talking about the structural injustice also. And she has recently published her book, which talks about passive patient culture in India, disrespect in law and medicine. So shall we all put our hands together for this panelists and welcome them? I call upon our co-chair, Professor Edward Pinto, to come forward, and as we lead this discussion, I want him to sit and the expertise in the field. Just wanted to focus upon what are the trends that are there in India, especially when it comes to the ethics. The current state of ethics as community practitioners, community health practitioners, the challenges, and later on we can also focus on the directions that we can, as a team, discuss and proceed forward.
I think we have less time. I think in interest of having more discussion, the panelists can restrict them to their allotted time, and we can have more, I'm sure already the first presentation has evoked a lot of questions. This session could be, while going back, if not many answers, we could have new questions which we can explore. That would be a good thing to go back with. All the best to the presenters. Each one, all the 4 presenters can have their presentations done first. And the rest of the time, at the end of the day, after the presentations, let us have a common discussion, combining all the questions that come from different presenters, starting from the first presentation, and maybe the comments from the floor. So I think if you can devote some time for a meaningful discussion, that would be great. So over to you.
Thanks for the introduction, Alfred. So I've been working in this wash component from last around 20 years. From 2006 I'm working. So I'm basically a community practitioner, and I work with the community rather than other things. And so if you think of ethics and all those things, there are a lot of questions arise within me also. And so starting from the area we select, and before that, starting from, see what we call, for example, we are working in some community here in Bangalore. And usually what we call communities like slum. So what we should call, do we call them as a slum community, or what are the other names we should call? So these are the ethical dilemma I used to have for many years, like almost 15, 20 years I have the same thing. And basically I work on the toilet issues because I am interested on toilet thing. So there are a lot of stories linked to the toilet and ethics. I can also share it with you. And before that, I will share, because for me, what Alfred has told me to discuss about the funding and dilemmas with the funders, community leaders, and government officials. So I can start with the funders dilemma and all. So through SOCHARA, we were working from some grants and all those things. In 2019, there was one funding agency. They told us like there is some component we can, on wash component, they want to give some money, it's a CSR component. And if you're interested, you can put up a proposal and all those things. So we put up a proposal for one of the area where we worked for many years, but suddenly the funding agency has told that we can't work in that area because our company stays somewhere here, and according to our policy, we have to work within 10 kilometers of the radius things. So we can't go beyond those sort of things. So then we choose one area. They told this is the area and all, and they told us to do some small assessment like what is the need for the community. So one assessment we found that there is a RO plant, water filter is not there, drinking water is not there, and toilet is the issue. In that community there are around 2,800 families plus, and 10% of the families didn't have a toilet, and they have to use a public toilet there. And public toilet didn't have a doors and water supply and all. But still people are using the space for defecation there. So that was the point, and we made a project and we got some budget and all those things. So that was the first assessment, and after that what we found was the area belongs to the military, you know. So if you think of the ethical consideration and all, it is a legal issue here. And the military person has told very clearly that you can't work in this area because it belongs to us. So see, if you think of ethics and all those things, so who has chosen this area? And for example, the people staying there from more than 140 years, you know, and they don't have rights in their land, but they stay there. And when they are going to vacate from that place, we don't know. It should belong to military. See, we can work with the government, we can work with the private land. You know, we can go to complaint and all those things. What about military? So we have an experience we have seen near that Baptist hospital, I think. So one school, overnight they removed the school. Means there was a court case happening, and it belongs to military, and court case was in favor of military and all those things. They removed it. So these are some of the ethical dilemmas we have in the areas where we work, and challenges like, so what we should do about these kind of things. See, one is like organization needs a funding, but sometimes we have to go along with the funders things also, and how to work on these components. So these are the things. And so second is about the need assessment. See, I am working on sanitation, or like when the project comes to us as an organization through funding, so they give the specific fundings. Like for example, wash component, you work on wash, and you work on some domestic violence, you work on livelihoods, you work on development like that. But when you go to community, so development, livelihood, wash component, domestic violence, legal rights, everything come into consideration. Then how we can only work on the wash component in our areas. You know, say sanitation may be a component. See, people need a toilet, but they also need a drinking water. They also need a housing. They also need a legal rights. Like the land belongs to someone, building belongs to someone, but they're staying there from last 140 years. So these are the ethical dilemma I have with me. And so how to answer those sort of things, you know, those things. And second is like even the toilet. Toilet is my favorite because 20 years I'm working on toilet issues. And I want to work more on toilet issues. See, every day there is a new thing happening on the toilet. So I can share one of the example somewhere in 2013-14. There was like, we used to work with a lot of network partners across Karnataka. So one of the partner told that in their area there are around 140 families, and none of the people have a toilet. And so government is not approachable, easily approachable and all those things. Can you help us something? So I told, okay, we can have something and we went. So I was trained on this behavioral change components and triggering community, building a toilet, training a masons on low-cost models and all those things. When we went to the community, they gather together, we trained them, I means with a team, trained them, behavioral change component, everything has happened. We trained masons also. At the end of the project, they told us, see, 140 families what we have in this village. His name was Daudabeta. They told us like, we understand all those things. There is a need for a toilet here. The question arise from them was like, we don't have money for this. See, that time 2013, they were agricultural laborers. They were earning around 140 rupees per day. And the expenses they were making for the family was 120 rupees. And the saving was maybe around 30 rupees. So how they are going to build a toilet? We were trained on building a toilet. It cost around 8,000 rupees. And they didn't have the money for those kind of things. So these are the ethical dilemmas comes to consideration when you go to field. There are hundreds of stories like that I have, because most of the times our team, we have around 17, 18 people. We are working on community, and these are the ethical dilemmas we face. And sometimes we don't have answer for those sort of things. Sometimes we, with the experience we have, we tackle these issues, but most of the times we don't have answers for these sort of things. So second is about, we have seen community. I told you, like, wash is component, we get funding from funder thing, like you are working on sanitation, toilet issues, all those things. The thing is, like, if there is an issue arising on the domestic violence, if there is an issue arising on the social security schemes, if there are issues arising on other aspects like legal rights, so how to tackle those kind of things? That may be the first priority for community. For us, it may be a sanitation and toilet, but for them, first priority for them is a legal rights like that. So some of these things, these are some ethical things I feel that need to be discussed more, and how to tackle these type of things as a group, we can go into the things. And sometimes there are a lot of political interventions. This is also one of the things we always, feel like in the community where we work, we call it urban poor locality. We don't call slum, urban poor localities and all. So there are a lot of political interventions in this community, so one of the community, we have seen that there are one of the local person, they kept around 15 boys in the community, in the rented house and all those things. And they always provide the drugs, ganja, everything is very common, in our community, this is very common thing. They used to provide and to monitor this area, So this is a political interventions we face. In the community, we go with something else, but there is something else happening and all those things. Yeah, and apart from that, yeah, so these are the things I just want to put into the things for discussion and all. And there are a lot of ethical issues comes to the consideration when we work with the community. So we can have discussion further on those things. So yes, sir. That's it from my side.
Thank you, sir, for bringing the practical aspect of the ethical dilemmas where you stand in between and you don't know what to do. There is always a boundary between the community and the practitioners. When we go to do something, they see us they have come to take something from us rather than they're here to help us. That's a challenge, and I had been with him, especially working on these urban poor localities health aspects, where some of them ask, how much commission will you give? What is the total budget? And some people, they will ask, which party are you? From whose side are you coming? And community leader says, whatever you do, it has to go through me. Put my picture, my name in everything. Even when you conduct a small health awareness program, they say you do that. These are the challenges where, as community health practitioners, we feel stuck sometime. And sometimes we question, am I doing the right thing? Where should I draw the line? All these aspects. Thank you for bringing. We'll reserve the questions to the last. Now I'll ask Ameer sir to share about the community action for health in Tamil Nadu, especially working with the government and the government systems. Thank you.
I'll just use this. Good morning all, and thanks for this opportunity. I thought like we can, I could share with you about two decades of experience on promoting the community processes of health in Tamil Nadu. So that's the kind of the experience where I come from. And it's not a kind of individual or individual organization's experience. It's a collective experience. We are all in Tamil Nadu, we together with many organizations, we are trying to promote these community processes in health. Means like community participation in health. And even to actualize the community right, or kind of the community right for the community to take part in decision making in healthcare sector has taken almost 70 years to actualize. And in India, we all know that from Mudaliar Committee to Bore Committee and to Almata Declaration, everyone talks about the importance of community participation. But in actual terms, when NRHM was born in this country, when NRHM introduced in this country, And it took about 60 years for us from Borei Committee to NRHM 2005 to actualize from a policy to program to implement the community participation. So the NRHM is the first program who gave a legitimate space for the community to take part in decision making, implementing, monitoring, and so on. And that's where, and we all believe that, and we all know that for a primary healthcare, community participation is a crucial concept. And how did we kind of actualize that community participation in real term? What are the challenges we faced? And each state is facing different kind of challenges, which we know, like we are all aware of, at least from India's perspective, like each state, because health is a state subject, and each state has its own policy, and each state has its own challenges to promote this community participation in their own state. So my experience comes from the state where I belongs to in Tamil Nadu, and our work starts from maybe like in 2006, when we had a discussion with the Director of Public Health Services in Tamil Nadu, who is a renowned public health expert, who is no more. And we had a discussion with him, like, we have to create spaces for the community to take part in decision making, all this aspect. And in NRHM, that time NRHM was kind of, it was very initially started. And if you look into the NRHM components, there'll be 5 pillars. And one of the pillars of NRHM says like, community processes in health is an important pillar to real kind of, achieve the health for all goal in the country. So that was kind of one of the important pillars, the 5th pillar. It's not a 5th pillar or 1st pillar, but it's one of the 5 pillars of the NRHM framework. So when we had a discussion with that health secretary and the Director of Public Health in Tamil Nadu, the first question he asked us was like, what is the need of a community participation in Tamil Nadu? This was the question that's where we started from the entire process of establishing community engagement in the health sector in Tamil Nadu. The reason is like, here's a reason. Tamil Nadu is one of the highly developed states, and in terms of health indicators, it's kind of a second best state in the country. This all achieved without community participation or with a mere kind of a tokenism of community participation. When they achieved such a high indicators, obviously asked us, like, what is the need of a community participation? And at the same time, we all need to remember, like, we have in 1978, we have started health for all goal, and today we are in health care for all goal. There's a big difference, big shift in this goal. So when you shift from health to health care, the Tamil Nadu government or the bureaucrats or the decision makers, they also think like, what is the role of a community? When you think about health, there is a role of a community. When you think of healthcare, it's become a technical subject, where the role of communities become lesser and lesser. And this question started within the system, and it's outside the system also. So what happened, like, Tamil Nadu government has started reducing these community interventions. For example, from a non-communicable disease focused state to from communicable disease focused state to a non-communicable disease focused state. Like, the goal itself shifted from reducing non-communicable disease to communicable disease to non-communicable disease. That means like you need a more technical work to do rather than the VHN role and ASHA's role, where the community workers takes community problem into the system, but where the system itself decided to focus on the non-communicable diseases, where you need a kind of a staff nurses, where you need an expert, where you need a kind of expert doctors to treat diabetes and all those non-communicable diseases. So the couple of things has kind of put up the challenges before the Tamil Nadu government to reduce the community health work or community health workers' role in Tamil Nadu. In today's context also, Tamil Nadu has very less number of ASHAs compared to other states in India. If you look at, Tamil Nadu just have about 4,500 ASHAs in Tamil Nadu, whereas many states has more than lakhs of ASHAs in their own state. ASHAs meant for, I hope you all understand what I mean, the ASHAs, accredited social health activist. She is the primary community worker in this country. But Tamil Nadu doesn't have enough community worker in the state. They have only 4,500 ASHAs, where they could have supposed to have kind of more than kind of a lakh ASHA could have been there. The reason is like Tamil Nadu government doesn't believe in this community role or community health workers role or link workers roles to improve the health of the people. They believe that the doctors and the system and the bureaucrats have higher role to play and to improve the health status of the people, which they achieved also. So highly bureaucratic, highly kind of technocratic states where we come from, where we started work to promote this community participation in health. So this is the context like where kind of our the local context as well as the global context has shifted from health for all to healthcare for all. So that's where we started. So what are the challenges we faced? There are kind of many things that I can share, but I just wanted to highlight few things. There is no trust among each other. There is no trust among the community on the health system. There is no trust on the health system on the community. For example, if you say like, no, the community should monitor health services to understand it better, and community should do a planning for themselves to improve the health status, immediately the question comes from the health systems like, who are them to monitor us? It's not about money. The primary essence is missing is like, no, what's missing was this their center is a public health center. It's a public center where center is working on the public money, and the community should take part in every part of the decision making. That's what even yesterday's research aspects also in this conference was talking about. But where is the community role in taking research? Research doesn't mean that to do a kind of a researcher, a PhD scholar go on doing research. A research means a real beneficiary has to understand what is the status of the services. That's mean the people's research. For that, the people have to engage. For that, the people have to go and question the system. It's not about the question the person, it's to understand the system. But the very beginning stage itself, the system asking, who are you to monitor us? But at the same time, we have village and water and sanitation committee in the country, VSWC across the country. In every panchayat of Tamil Nadu, every panchayat of country in this country, every gram, every what is it called? It's even below gram panchayat, what is it? Revenue village. Every revenue village has one village committee, village health committee in this country. The role of the village committee is to go and monitor, go and question the system, do a planning for themselves. It is one of their role. It's a legitimate committee approved by Grama Sabha. But when they do start to exercise their responsibility, the system asks, who are you to ask me? This is not a simple question. The power dynamics comes here. I am a MBBS, not only MBBS, Ayurvedic, whoever may be, okay. I respect all of them. So there are many good friends of doctors. And yeah. But they come from a power packed mindset. That's what the system taught them. Like, no, I studied for 6 years and internship, and I am here to treat you. And who are you to question me? This power dynamic starts here. So that means when we wanted to promote community participation, the power has to shift from here to here. Unless this power shifts from a top-down to equal stakeholder relationship, you cannot have a real community participation. So that for that, the system needs to understand, the system needs to have a trust on the people, like, no, they are not questioning us, they are not below us, they are equal to us. And the community also need to understand that we didn't get a super power through the village health water sanitation committee to question them. It's not that. Together, can we do something? So this mutual respect, mutual trust has to come, which was missing even today. And it cannot come also. And without any kind of a considerable measures. The second thing is the transparency. And what kind of a transparency system is maintaining? If the system is really transparent to the people, that means, for example, a sub-center which receives funds from the government and which collects taxes from the people, it is supposed to submit their account to the Grama Sabha, isn't it? Because it's their money. Every Grama Sabha should have an audit of this particular health center. This is what written in the constitution, means like NRHM framework. But even today, none of the Grama Sabhas, none of the health centers are submitting their account to Grama Sabha. Unless this kind of a transparency, I'm just taking this one example as a transparency. That doesn't mean only the financial transparency. There are many, many things that has to be done. But so unless this transparency increases, and we cannot have people to have a confidence on that. And the other thing is the inequity. It's not by one, I'm just saying like all these aspects. The inequity aspects of the healthcare system. Inequity doesn't mean that, I just wanted to kind of answer to Jacob also, the discrimination doesn't start at the point of care. Nobody asks you like, no, are you Dalit, are you Muslim, are you Brahmin to treat you? No. The discrimination starts from the health awareness and health education and health seeking behavior. The health seeking behavior and health education comes from, unless the system takes kind of a considerable amount of effort, the health awareness and the health education or kind of health seeking behavior is not going to improve. Unless that improves, you're not going to go to a center. And if you don't go to center, you're not going to improve your healthcare. That's where the cycle. So the system has a role to treat them equally and to educate them equally. I have a power, I have a knowledge, I have resources to increase my health education. But that may not be the same case for my fellow being. Where that's where this discrimination starts from. For a state like Tamil Nadu, which is a highly developed state, which at least claimed to be highly developed state, should have this kind of equity culture in every aspect of the healthcare delivery. And then quality of care. Inequity does, so we have to look at very nuances. The inequity starts in terms of kind of this kind of knowledge, and in terms of quality also. For example, I can bet you in India, Tamil Nadu is the only state where every district has a government medical college. Every district. But what is the quality of care? We create medical colleges, we get funds, but there is no doctors. There is no enough beds. There is no proper treatment. So what is the point of getting kind of every medical college in every district? Yes, of course there is a benefit. To get a political benefit, a political mileage. Of course that is needed. But unless the quality is improved, unless we have enough resources to take care of that particular medical college hospital, there is no use of having a buildings and the chairs, and you're going to be rusted. So the quality is the other important problem of kind of inequity, I would say. And then regional disparity. And the regional disparity. And in Chennai alone, we have around 5 medical colleges. But whereas the adjacent district of Tiruvallur district, a person, if he wanted to have a kind of a chronic disease patient, if he wanted to get a medicine, either he has to come to Stanley Medical College, almost 60 kilometers far away, or he has to go to a Tiruvallur Medical College, which is impossible. So what do? They either go to private medical care, or they kind of they don't take medicine. But whereas where I live in just close to Kilpa Medical College. So this is the inequity which Tamil Nadu government should take it up. So regional disparity. I am a privileged citizen who lives next to Kilpa Medical College. But my fellow beings kind of living 60 kilometers away from the medical college, where he or she cannot have the same treatment. That's where the inequity, we have to understand it in the nuances. And then the power dynamics within the system. Starting from health secretary up to the VHN and kind of below VHN, the ASHAs now, like every cadre has this power, how do you say, the power accumulating kind of a position. And the system is kind of divided into bureaucratic and technocratic. All this, this is one set of kind of differences and power dynamics plays there. And outside the system, the community power dynamics. Even today, not even today, even every day, every time it is there, like Dalit community and other community cannot come together, and they cannot come sit together, and they cannot sit together to do a planning, and they cannot do health plan for themselves together. So the fragmented community, and then more and more fragmentation happening within the society because of other aspects which also affects the health of the people and kind of a togetherness of the people. That is where these power dynamics comes into play. And and I would want to say, without the kind of the other aspect which is affecting this kind of community to just give it up, like the populist policies, rather than the kind of progressive policies. What is the populist policies? In Tamil Nadu, for example, the maternity benefit scheme, maternity assistance scheme. Now, each pregnant women will get around 18,000 as a maternity assistant scheme benefit. But it started from 6,000. DMK gave 3,000 rupees, ADMK government gave 6,000, DMK government gave 12,000, ADMK government gave 18,000. If the next time ADMK government comes, they will give 25,000. This is all increasing the amount, which is very essential, which will be very helpful. And whether it's help to that particular women or not, that we don't know, but at least it will help to that family to improve their status, whatever. But the point is, are we satisfying with just giving a maternity benefit scheme and claiming that we are a 100% MCH care state? If you take it up, the statistics of Tamil Nadu, you will be surprised, or kind of, 99% deliveries happening in the institution in Tamil Nadu. 99%, either it in private or public. But that doesn't mean that you get a quality care. That doesn't mean that you are not discriminated. It doesn't mean that you are cheated or kind of you are kind of you are undergone irrational treatment in the private system. So government is satisfying with the maternity benefit scheme, whereas the community requires more and more than the maternity benefit scheme. For example, 60% of deliveries among this 99% is happening in the private care. But Tamil Nadu doesn't have a proper legislation to monitor, evaluate, and control the private healthcare system in Tamil Nadu. Every other citizen of Tamil Nadu is going to private care. There will be kind of, and you will be surprised, the first corporate hospital in the country has started in Chennai. Whereas the public system is also robust. It's a dichotomy. We also promote public health system, we also promote private healthcare system. But without any legislation. So that means a woman who's going to delivery care in a private healthcare setup will definitely will go and undergo a kind of exploitation. We had done a study. I'm going to finish it off. A difference between for a normal delivery in a private hospital ranges from 3,000 to 90,000 in Tamil Nadu. 90,000 in Kanyakumari, 3,000 in some other village. This is the variation. The government doesn't have a control or kind of a role to regularize this kind of a difference in prices, delivery care charges. Definitely they have, but they are satisfying to give this 18,000 and claiming that we are a developed MCH state. So these are the kind of dilemmas which kind of preventing community to really take part, our community to be sidelined, and the government is not giving a space to kind of people to take part. Just last 30 seconds. And there are institutions which is developed in this country to community to take part legitimately in all these aspects. That is Patient Welfare Society, Village Health Water and Sanitation Committee, and recently Jana Arogya Samiti in Health and Wellness Center. All these committees meant for a active and a kind of a robust community participation. I can challenge you, and otherwise you can show me like which is the committee, which one of these committees anywhere it is working in this country. And so my point is like, it took 60 years for us to actualize the policy to program. After 20 years of NRHM, now in 2025, after NRHM 20 years, we created these committees, we created legitimate platforms for the people to take part, but even today, the community doesn't have enough space or legitimate space or kind of a kind of a understanding or kind of a promotion to really actualize these spaces. And top of that, this discrimination and kind of this inequity is happening. So these are the dilemmas. There are many things to discuss, but I don't know how time. And anyway, thanks for that.
Thank you, sir, for beautifully bringing out these aspects of the background of Tamil Nadu health systems and also the challenges like trust, the power dynamics, transparency, inequity, quality of care, regional disparity. And many of us might have many more questions. We'll reserve it. We'll try to finish in another 20-30 minutes, then we'll have ample time for discussion. You can feel free. Now may I invite Supriya to come forward and speak on the title, Emergence of Ethical Issues as Deeply Embedded Within Structural, Cultural, and Relational Contexts.
First of all, thank you so much for having me here, especially for SOCHARA. And of course, for many of you who have been actively being part of this, creating the space and holding the space. So thanks, Janelle, and then of course, Alfred, and for Prahlad and Thelma, who was actually involved me in the space. So I tend to go on tangents a lot, so I have my script ready. So what I'm going to do is, first I want to quickly ask you a question. How many of you are actively involved in community health as a practitioners or some way of community health discourse? Could you please just quickly raise hand? just to get an idea of who I'm talking to. Thank you. Right. So I just want to begin by saying that, of course, as many of you already know who are actively part of this, that bread and butter of community engagement, whether it's health, education, or any aspects of any institution's works which we do, is not, of course, a technique or a training, right? It's very often, at least as a researcher who works very recently, have been engaging closely with community, is about sitting with discomfort and having to build trust, which I think Ameer and Prahlad has been engaging with these questions, and also integrity. And the key aspect to develop all this and to engage is time, which very often, very, very often, researchers, especially who are sitting in the neoliberal academic industry, which is also with some of the NGOs, which also have a time limitations, which we don't have because of the rigid timelines and milestones which we want to, catch up on. So, and perhaps most importantly, it's the willingness to engage with the diversities within a community. So I think which Prahlad and also Alfred was, Ameer was talking about, was about how do we talk with different communities within the larger community. The idea of community, we need to, we need to critically ask questions, who am I talking to, and who am I actually accountable in when we have this conversation, especially when we think about even research with the community. So before I reflect on a specific ethical issue, because there are so many ethical issues which comes through from my work, I just want to quickly say it's important, as I said, to what do we mean when we say community health, and why does this matter for those of us who practice it, teach it, or just beginning to step into it, that is me. Too often, community is treated as a bounded, harmonious entity, which we definitely know which is not the case. So, but for practitioners, especially on those on the ground, I think which already we have heard, it's never one thing. Community health is entangled with inequalities, histories of exclusion, contested identities, and shifting power relations. And especially in a country like in India, where there is oppressive conditions and larger structural discriminations, which is again not a new thing, but the degree varies from different countries to different situations and contexts. So, and it is here that some of the most difficult ethical questions emerge. It's not necessarily always a dilemma. So it's like not like a black and white or the right and wrong, very rigid questions we have as ethical issues, or we need to resolve it. But it's more about the ethical issues which emerge in the larger context and why we need to think through critically. So one of my earlier research project was on informed consent. It's very boring, taken for granted ideas, which many of us we start with, especially in the global south. Oh, how do we think about this? That was my work, which I initially looked at. But over time, I stopped using or engaging with this like abstract autonomy, all the principles we even in the morning in the panel discussion, not the panel, the plenary discussion which we were listening to, the abstracted, decontextualized, and disembodied ethical concepts. What does it mean in our everyday, those questions, which I started to think through. So I wanted to understand what this bureaucratic, ritualistic, it's a form or it's a practice meant to actually look like in everyday, lives for us, and especially for people or persons who have been marginalized, oppressive, larger conditions. What does it do, and what does these ethical concepts do? Or how do we practice or not, or navigate or negotiate? And it's a struggle, it's a site of struggle. So I would see ethics as part of the struggle and negotiation. So by the end of my doctoral and postdoctoral research, I came to argue that in settings where individuals, especially for those marginalized, especially patients who are marginalized, who are not seen, who are not heard, who have been silenced and oppressed, respecting a person, when you don't even respect a person as person in India. For example, when we were walking in the, the road, not in the very high-end Bangalore I'm talking about, when we just walk, the pedestrian part doesn't exist. The question of where's a dignified life? Then the question becomes is, how do we talk about dignity or respect or autonomy or all these grand concepts, but in everyday, how do we practice it? We do practice it, I'm not denying the agency, but how do we practice is what the question which I went through and looked at, and through the lens of how the problem is then is not about, very often sometimes global south scholars or some of the scholars we are doing decolonial approach to the bioethics concepts and ideas, we tend to ask this is a Western problem or the global north issues, or it's like a top-down approach question. But then we need to interrogate really what do we mean by how do we negotiate in everyday practice, right? So the problem is that we invoke these terms without interrogating the violent hierarchies and institutional disrespect that prevent them from being meaningful. That is, how can these consent forms or autonomy discourse, all these concepts, whether it's a community health or it's an everyday clinical care, how do we make this meaningful is what we need to really ask questions. So then I mean, actually, I'm coming to the main point here. I would see it as for this panel. Due to my own existential crisis of being in academia, or still continuing to be in academia, what am I doing this? What is this research for? Am I just writing for papers and books and then job, promotion, and X and Y things, which we always struggle with? Then what am I doing? And that's my existential crisis, where I'm in the current space of community engaged work. Not co-design. I mean, that's a whole ball game of, again, the neoliberal academia which is playing in. I'm not saying who do authentic and ways of doing it. I'm not critiquing them, but there is a lot of larger co-design and community-led research projects, but done by the scholars who are sitting in the university. So I'm trying to see ways, how can I resist it? So I found myself returning to the question, what an ethical theory actually do in the context of community engagement within the larger conversation. So for a while, my answer was nothing. What these ethical theories does, what these values and principles do. But I just wanted to go back, and one of my unlearning journey and one of my key unlearning spaces where I'm thinking is a huge influence by critical scholars, and one of them was bell hooks. So for her, and the way I have learned is, theory is not inherently healing, liberatory, or revolutionary. It fulfills this function only when we ask that it do so and direct our theorizing towards this end. So that means the theory only can do what we want it to do as researchers or community practitioners. So a theory is something, an ethical imagination then, right? I mean, especially these ethical concepts and ideas are the ethical imagination. So not to simply apply principles or values, whatever the grand abstraction we have, but to critically reflect on how injustice is sustained through our systems and even through our own research practices, especially as researchers, which we need to be aware of, to imagine other possibilities and the ways we want to do it. So most community health practitioners and researchers I have met are already drawn to justice and rights-oriented framework. Many of us are in this space because we want to do something good. But then how do we make sure this paternalistic or sometimes a savior complex would really harm the community conversations, right? Then the question becomes much more, which we need to take a step back. But the key challenge is, or even sometimes it's a key practice which we need to do, and again, I keep teaching my students, and also I try my best in my own research, is to practice reflexivity. A critical reflexivity of our own positionalities, our own backgrounds, and every moment it comes through in our practices across. So that means acknowledging our social and political positionings and the positions, the privilege we carry, not always, sometimes definitely a lot often, and being willing to sit with discomfort. So as I don't have to tell practitioners in this room, when communities will make you aware of your place, when you really want to work with them, want to work with your community, they would tell you, you don't belong here. Just off, right? Whatever the off is here. Especially when you're engaging with them authentically. So it's not always gentle. It can be unsettling, even painful, and because we have this idea of like, well, I'm doing good for you, right? But that's the part of ethical work. To remain open to critique, to make mistakes, sometimes it's just to sit and to learn and be accountable, not just to our institutions, because very academic institutions are the whole challenge, like how do we hold ourselves accountable with academic, because of we have a research protocols, we need to keep on submitting certain reports because we have to do data collection, right, all those aspects. But to the communities we work with, whatever the diverse communities we want to work with, how do we be accountable? I think in both the earlier presentations it came through. So let me briefly share a recent experience from my ongoing work in Nilgiris. I started, as I said, it's my own existential crisis. I am from my, I have my own different shifting identities I carry, and I'm from my, my dad is from Badaga tribal community, who is like contested indigenous identity within Indian discourse, and also the state political climate. And my mom is from Gouda. So what does it do it's an interesting question around what's my power and what's my privilege, and where do I belong or I don't belong? Those questions come through it. So I arrived in the Nilgiris with a clearly defined research question because I had to submit to the ethics committee, right? So I had to write a research proposal. I did have a long conversation for many years, this project on, but still I had to submit a clear kind of a research proposal. How do women living with chronic pain in indigenous, the larger rural communities, describe and navigate their everyday suffering? That was my larger, because of my own interest and past research interest. So it was a question shaped by years of work in public health ethics and largely within the space which I work in. And by, of course, my growing discomfort with the ways of methodological or the hegemony which we have on certain training, certain research design. So I wanted to understand how, and I wanted to unlearn and take this as an opportunity. So, but research questions, no matter how carefully worded or how carefully we are trying our best not to do it, rarely prepare you for what the field actually asks you. Here, even to use the word field, I find it very, very challenging because it's a community who I know and who I work with, right? So should I say it's my family? I mean, again, this is the questions of categories and the concepts and ideas we are very often familiar with, but sometimes suddenly it makes you question, is it really familiar? What should I make these concepts and ideas or research frameworks and designs questioning myself? So my first real moment of entry was not through an interview or a consent form, which very often we tend to go, which I did myself in hospital settings. It was through grief. A woman from one of my community, she was my neighbor who was just it's a line house, so part of my, just 2 houses next the line. So she had passed away and I was, because you're part of a community, it's a close-knit community, it's 50 houses in a village. It's like really like, I mean, to be crude in many ways, it's like everyone is up in your business, right? There's no privacy, but it's again the larger accountability, the social ways of being. So being part of SAWU, that is death ceremony, is where how you show up and be part of the community, and that's what I did because I'm familiar with the way the ceremonies work, rituals. These rituals are not private affairs. They are community gatherings attended by villagers connected through kinship and shared labor and histories. I didn't go as a researcher, even though I was a researcher. I went as someone trying to understand what it means to be present, not to observe, but to witness. So that's a thing which I wanted to do. Even though I'm still witnessing, I'm still observing as a researcher. It's like a challenge in the dual positionalities which I work with in many ways. So we sat for hours with the larger rituals and the ceremonies. I didn't take notes. I didn't ask questions. I helped where I could, because as a woman, you need to be a good woman. I'm a foreigner now who walks in has certain privileges, so I need to do certain different kind of roles I have to play. The next day, a few women who had who had seen me at the rituals. I mean, I've been there for almost 15 days. They didn't much engage with me. We have been talking mostly about my marriage, mostly about my, why I don't have a baby, all those questions. But the conversation around research didn't happen. Only after this ritual, they noticed that I was there. I was showing up, right? So in the weeks followed, then the conversation started. Women started sharing with me. One of my auntie or part of the larger community told me she could no longer climb the slope to walk to the temple up. And then she started saying, what's the point? I don't have access. Because if you want to go to a hospital, a good, decent hospital, even a government hospital, you have to take at least 3 hours, right? It's quite, even though Tamil Nadu is really great, but also the access varies, depends on where you are located within the larger, especially Nilgiris is a hilly region. So, and then she said, they just give me pills, or they don't even recognize me that this pain exists. They just basically dismiss. Then the conversation started of how people, especially women, experience pain and the suffering and then dismissal, the everyday indignities, that's what I would call it. So over time, I began to understand that how do we understand the chronic pain and the larger understanding of how people reflect and report the idea of pain in itself. So that is something which is larger work around what I've been doing. But back in Sydney, like I am sitting here, a couple of my colleagues, or the ways we need to talk about, what are you doing, right? They asked me a question in India, but you're back in India, you're going back to your community, it's exciting. And they asked, did you finish your data collection? That's a very question, it's a normal question to ask. But that's where it just struck me much more, like, what am I doing here? What is this data collection? Who is this data, or the idea of data, from whom, right? So back in Sydney, of course, I had ethics reports to file. I had to do certain things. A collaborator asked, kind of like an intellectual collaborator, the more we think about, did you finish the data collection? But I'm like, I haven't even started, right? I mean, any kind of building trust. How do we build trust? How do we think about integrity? And we need time for everything to happen. So as someone both insider and outsider in a different ways, I don't want to use this kind of a dichotomy because we carry these embodied identities and histories with us in different ways. I felt accountable in more than one direction. To the women who were slowly trusting me with their stories, with their suffering. To the funders, in a way I don't have funding, but the kind of a protocol for my ethics committee, right? So what I realized was that what can ethical research do? How can ethical research with community, especially if you want community to engage with your work, how is it possible? What do I want to know? It's not just a question, right? It's not just knowing, because research is all about knowing. It asks, whom do I answer to and how? And what this knowing does to whom? So this work taught me, or at least it's just the beginning, and definitely this is like a surface in a way. It's taught me that time in itself is ethical. To give time in, be accountable in itself is an ethical practice. Not just as duration, but as presence. Not just as scheduling, but as staying with uncertainty, with repetition, sometimes with discomfort. So sometimes it begins with just showing up at funeral, just to be there, showing up to the community that I'm there. But I can't be there always, right? That's another whole question altogether. Sometimes it's about being quiet in home where suffering can be shared and pain can be shared and also joys can be shared. I did attend weddings too at the same time. And how do you contribute then, the conversation, how it leads. So what I wanted to return to the title of this panel, from practice to education to translation. I want to say this is ethical work in community health or any kind of community engaged work can't be pre-packaged into toolkits or checklists. Very often we think ethics is about, oh, autonomy, I did it, or informed consent, I did it. And then sometimes people don't think really about justice, how it is an embodied practice. I mean, anything, all these concepts too. So it has to be felt, practiced, and constantly relearned and unlearned. And what does it mean is that ethics is about situated way of beingness, right? Then how do we wrestle with that when there is this prescriptive nature of these are the principles, you're good to go, you have a master's of bioethics, right? And what does it really, then the idea is practicing reflexivity, and I think that's the way which I'm thinking through. How do we practice ethics, or how do we be ethical in the larger community conversation? So, and just to quickly sum up, if we are serious about community engagement, we have to be serious about the messy and difficult, and of course, I think it's a beautiful task of holding ourselves accountable at every power or privileges and positions we come with, and not just to whatever the institutions demand us. And that sometimes we maybe to say that I'm not doing research too, I think. Thank you.
Beautiful presentation on how to be ethical in our research, especially when it comes from your own community, how you were able to fit in both as a researcher and a community member, and which gave an impetus for you to think. And I was impressed by the word which you used, reflexivity. And most of the sessions from yesterday till this point, most of the panelists or the plenary session speakers, they were talking about something critical, reflexivity and reflexivity. I think ethics has something to do with this, where we sit, think, reflect, and then act upon it. So wonderfully you have brought out this idea. I just want to thank for this beautiful presentation. Now may I invite Dr. Nancy to come forward and kindly share your presentation.
Good afternoon, everybody. So I think you heard the heart and soul from the community, and now I am coming from a position of ivory tower of academic institute and how we educate ethics for students. It's a difficult task ahead, but just let's start. So how many of you feel that the medical education and health professions education in India adequately teaches ethics? Please raise your hands. You can try, you can guess, those who are not from India, others. How many of you feel the education is sufficient to teach ethics? Okay, good point. Others? None of you have raised your hands? Are you sure you got the question right? Okay, so yeah. So I'm going to share how ethics education happens in health professions education with focus on MBBS and MD students. And of course, most of our time is spent in the community. I'm from community medicine department, so I'll share a bit about that as well. If you go through the National Medical Commission's fantastic document on the medical education regulations, it lays out a clear guidelines on how ethics can be integrated into medical education through various competencies. It's amazing. It even gives the different teaching learning methodologies and how to evaluate the students as well. So on the outset, if you see, it looks really good. But how to implement is a challenge we all know. I think that is why you have not raised your hands. So in the foundation course, regularly we include ethics and mental health. And one of the methods that we use, I'm just going to use it on you. So in India, we have this health worker called Anganwadi worker, who is very crucial in providing child health services for 0 to 6 years old children. She takes care of the children in the community, around 40 to 50 children, taking care of their non-formal education and nutrition. And she is very crucial for health system. So if you feel all Anganwadi workers should be females, please stand up. If you are unsure, come to the middle of this room. And if you feel they can be males also, you can continue to sit down. Say they should be females, stand up. You're not sure, you're not even sure what this question is about, you can come to the front. And if you feel they can be males as well, continue to sit down. All of you are sitting down? So they can be males. Males can take care of children, 0 to 6 in the community. Take care of the education. Yes? Women? Okay. So Alfred is bold to opine his frank opinion. Others are thinking, I'm a faculty at Azim Premji. If I get up, people will take photographs. Men can take, sir? Oh. Okay, good. Only the women. So Philomena? System, you are right, sir. Yes, yes, they are capable. Philomena, how many of the Anganwadi workers you have seen are men? None. Okay, none. So no men are appointed as Anganwadi workers in the country? No. Okay. So when I ask this question, this quiz, it's called the walking quiz, most of the students come to the center or they stand up because they feel that women are better suited for taking care of child care. And then they think, they discuss among themselves, there is a buzz in the room, and they fight with me also, argue and discuss, and that's where the discourse starts inside the classroom. So this pedagogy technique works very well even with a large room full of 150 students. So I just want to stress that starting from foundation course, we include ethics through these kind of practical examples. When you bring in the slide on 4 pillars of ethics, non-maleficence, beneficence, nobody can connect. You have to bring in real life examples and then make the students to think and have quiz. We have logos and quiz on how many of you know that Ayushman Bharat, the universal health coverage scheme is there, and how many of you have ABBA cards. Do you feel free healthcare is freebies? So it is called in social media. Freebies should be encouraged, and then they think, fight, debate. So these are the things, pedagogical methods that we employ inside the classroom to have the discourse on ethics. We have the ATCOM, as you can see the expansion here, attitude, ethics, and communication modules for students. We use movie scenes because when students have this, looks great on the curriculum, early clinical exposure. We have nursing faculty here, Nisha ma'am. So you are literally teaching children. Your students are 16, 17, and 18-year-old who are still having an undeveloped prefrontal cortex, having struggles with logical and critical thinking, and you're taking them to early clinical exposure to ICUs. People are dying there, complex emotions. And then moral distress arises. Why did the doctor decide to give the kidney to that person? How can I ask this question in rounds? Rounds is so scary. The chief doctor is often a male, a scary person. How can you ask this question? And then the delivery is happening, everybody's shouting, push. And they have this complex emotion, even joy on seeing the babies cry. But there is no place to reflect on it. And AdCom provides a good teaching method and evaluation process in which students can let out these kind of challenges that they are facing in their early clinical exposure, as well as a lot of communication with the patients as well. And one of the things that National Medical Commission mandates across the country, irrespective of whether the medical college is a government or a private medical college, is this on-paper amazing program called Family Adoption Program. Each student is given a maximum of 5 families in an urban underprivileged area or a rural area, and they act as the first point of contact for the families. Amazing, right? So we use this opportunity, as you can see in the third picture. So we walk with the students. The bus stops somewhere in the village, and most often the villages have 2 villages. Anybody can guess why one village has two villages? So there is a Dalit colony, and there is this main village. And the bus often stops at the place where sufficient parking is there, and then you have to walk on the mud road to reach the Dalit colony. And then we walk, we experience the walk, and then ask the question on why we have to walk this much distance to reach village number 2. It has the same name, but you have to walk so much. Sometimes they have 2 Anganwadi centers as well, one for the Dalits and another for the non-Dalits. Why? And then we enter homes. We have the picture of Ambedkar. We have Buddha. And then ask why. We are in India, where majority of them practice Hindu. Why do we have a Buddha here? What is the reason? And then most often medical students are from very privileged backgrounds. Even if they are from scheduled tribe community, they are unaware of the socio-political environment in the country, and we have discourses right in the village itself. So this offers a wonderful opportunity to discuss in the field and experience many of the things which are difficult inside lecture halls and in textbooks to experience. And we have in St. John's, very specific to our institute, is the Rural and Urban Orientation Program, in which the students, right from first year, we take them out into the community, be it village or urban underprivileged area. This is a stand-apart program apart from the family adoption program, and we work with the community. You can see one of the students frustrated. Why? He's never washed his, I don't blame him, but most of the students in lecture halls, I ask, how many of you have washed your own plate and cup in your home? They don't raise their hands. They're coming from so much privileged community where most of them, their mothers or the domestic help, who is washing, and the first time they are cutting an onion or peeling a garlic, and then wondering, why haven't I ever done this in my life? And we have this discourse right in the kitchen or homes of the community, and the community acts as the textbook. And it's the experiential learning that we have had. And many of the times in the community when we walk, we watch the woman washing the vessels, washing the clothes, and then the question is asked to the student on, why haven't you seen the men washing the clothes? And then we have discourse on this. So this is the kind of opportunities we have. We also have at St. John's a unique program called Community Health Action Program, in which students do an action project in the village itself. They're taken, the first pictures, if you see, we take them to NGOs who work with people with disability and other disadvantaged groups, and experiential learning is used for them to understand these kind of lived experiences. The last is a palliative care center. So many of the time in the hospital, core clinical palliative health is provided, and students can't connect to those kind of things, and these kind of community hospice care gives them a good exposure to complex ethical topics which we can have discussion. And in St. John's, we have initiated, we are very proud to say that we have initiated this unique program called Peer Mentorship Program. Because students often face complex mental health and ethical challenges which cannot be addressed in a 150 students classroom. We need this, and often a faculty themselves come from a place of privilege with whom they can't connect. So we've introduced this peer mentorship scheme in which a peer student can address the fellow students' relationship issues, ethical challenges, moral distress when they go to hospital, and their own mental health challenges. So we are starting it now, we are pilot testing it, and mostly we'll share the results. And humanities is a very important division in any institute. The NMC, National Medical Council, also encourages for certain lectures to be integrated with the humanities division. It's a great opportunity, but unfortunately, most medical colleges do not have a humanities division. Even if they have, they are underpaid, overworked, and then used as tokenism. So St. John's has a very strong humanities division, and we've used the opportunity to conduct exhibitions such as this, in which unique populations, this was an exhibition on commercial sex workers and their lives. And students had this immersive experience of engaging with different senses and listening to the experience and lives of commercial sex workers. And this is our director who was explaining about complex concept of human dignity and in connection with unique populations like sex workers. So students listen to this, but when we teach in the lecture, they sleep off or they don't connect to it. And I'm a faculty, so that connect is very difficult. So these are all the nice stories, but the challenges that we have faced is, it's very difficult to implement this. Some of the things I told is not feasible. It's so nice to say in a controlled setting, it's very nice. But when you go to a government college or where faculty shortage is there, students are 250, it's very difficult to implement. What happens is, convert all the competencies to lectures. Teaching learning method, the only choice chosen is lectures. And then with lectures, you know what happens, how the knowledge gets translated, it gets lost. And I'm a postgraduate coordinator, and we teach community medicine students, postgraduate students as well. With the postgraduate students, there is ample opportunity to teach complex subjects. Even some of the things that we have discussed, one of the teaching learning method is journal article discussion. And we've now started talking about global south, global north, and power imbalance, and difficult concepts also are started. And research ethics is a very important competency that is covered in the postgraduate education. And in the community, like these visuals from the community serve as textbooks for the students. Like why? What about poverty? What is lived experience of poverty? What it means to be a poor person? I'll just mention one point about teaching community health workers. So the traditional pedagogic techniques don't work for community health workers because they're adults earning salary, and adult-based teaching learning method is complex, time-consuming, and not very feasible. So we have experimented on different methods. These are, the last 3 photographs are taken in the tribal area, Asha workers from Tamil Nadu, and the top one are village health nurses from rural area of Tamil Nadu. And we have experimented how we can teach 4 principles of ethics in mental health. How an Asha worker can provide mental health to another person without doing more harm, especially in the case of suicide. And one of the things that we have done is listening to them, just listening to them. Because they themselves are all females, underpaid, overworked, and disrespected in the hierarchy of healthcare system. And then also from there on, work on that to teach the principles of ethics and how it can be applied to mental health. So with this, I will wind up on the different pedagogy methods as well as challenges in teaching community health and ethics. Thank you.
May I invite all the presenters to come ahead here? Yeah. Jacob, yours, yes. Thank you so much, and I think it was a very enlightening and diverse kinds of sets of experiences, starting from USA to other, India, then also being in Australia and Sydney, and your experiences. I think our thought today was about ethical considerations in community engagement for health. So let me just pick up 1 or 2 points and then leave some time for discussion. So keeping this theme in mind, I think across all of you have highlighted what a community is, starting from patients, and also Prahlad and others also have dismantled some romantic notions of community, the power, the elitism, who decides, and what is the power asymmetry, including the powers of oppression and domination within the marginalized communities. All those things have come up. And this brings out the complexity of, practicing or ethics. That is one of the important things I think has come. So I have picked up this power, identities, context, elitism, elitists. This is one part that we have spoken about. The second one is, of course, Jacob, you began with the idea of bias. So the issue across the presentations is about when does bias becomes prejudice, and when does prejudice becomes violence, and when does violence becomes injustice. So that spectrum of and where exactly do you pitch? Do you say bias is a human condition, and only when it becomes violence is it is politics, or whether bias itself is politics? How does bias emerge? How we look at others. It is socialization from a particular point of view, that you are born, you are socialized, you would never question those biases. And yeah, you have given, Supriya has given us antidote of reflexivity. How does it, taking forward? Is it only acknowledgement of where I am, or also doing something about how I can change my worldviews about others? And what does it take, including questioning the so-called research protocols, or going beyond? It also requires sometimes violating the set norms, and you challenge them. So I think, and yeah, last question that you have is, how do we do this? How do we pass this on to a newer generation? What newer methodologies are required? So I think with all these things, about one important thing that has stood out is that we require a kind of a paradigm to think differently. You require social justice framework within which you can embed and understand these things. You require transparency, accountability mechanisms to ask for compliances, adherences. And also we have spoken about communities. I'll come back to the last point about where ethics is not about only following certain checklists. It is also empowering communities. It is also building citizenship. It is also like what happens if all of your numbers are very good, because in public health we are busy with crunching numbers. Bring down maternal mortality, ratio, bring down infant mortality rate. Suppose everything becomes zero. Do we still require ethics? Is the question that is before us. So the question about, and Tamil Nadu has brought out this discussion, even if your numbers are good, what these numbers are for? Is it just for public health is only for number game, or is also building communities, building citizenship, building accountability, building transparency, building a just society? So that is all that we are, these are the few thoughts that I have picked up. I'm sure there are many more. So now we'll open up to the floor to have some questions. We have about 8 minutes on the clock. Maybe we can have another 2-3 minutes more till we pick up 2-3 questions at a time. Then I will direct it to panelists and we can have them. Yeah. Anybody who would like to start with?
Hey, my name is Dr. Dilip. I am from ICMR. My question, it's basically a question as well as a comment, and that is to Dr. Nancy. Madam, what I feel from your presentation is that, ma'am, maybe rather than giving the ethics education directly to the students, we should think about training the faculties first, because most of the faculties, I'm not talking about the premier institutions in India, there are other medical colleges where there is faculty shortages as well. I studied in a government medical college, and I know how the faculty shortage affects the students. Even in my final years, there were no lecture classes as such. So there are medical colleges where there is staff shortages. And recently I came to know that they are teaching ethics with one slide. In one slide, they teach all the students related that ethical aspects they teach with the 4 pillars and those things. So I feel that rather than going directly to the children, there should be something that, a training program, something like that for the faculties. Yeah. Yes. Yeah, thank you.
We will take up another 1 or 2 questions, maybe related or unrelated, but then we can take them up together. Yeah, Azim, yes.
Hi, I'm Azim. I teach in Azim Premji University. One comment, first of all, to all panelists. extremely good panel, especially after the plenary, which was very abstract and decontextualized. This was much more real. And special commentation for Supriya's presentation, really enjoyed that. But one question to Dr. Nancy to connect with that is this experiential learning, because we also do this quite a bit. There is a lot of ethical dilemma on us as well, that how do we treat the lives of marginalized communities in this whole thing, because it's almost like we are objectifying it for the privilege to learn from it, which is deeply problematic at some level, right? As in, because they are at a powerless positions, we feel we can walk into that, but in gated communities, we don't walk in because we cannot walk in. They will stop us from walking in. So how do we think about experiential learning, which is important, but yeah, this kind of power dynamics.
Okay, thank you. Maybe one more question.
Hello, I'm Gayatri. I don't want to tell my background here because the question is as a non-professional to Mr. Ameer, and one more question to Dr. Nancy. Question is, as a lay person, as a public, whom to question, what to question, and when I don't know about the ethics and what are the ethical principles. Just I'm asking. And to Dr. Nancy, I want to say one thing. What we are practicing in nursing college. We have the preclinical sensitization classes for our first year students. So we do explain them how to interact with the patients and how to manage all that, but not exactly the ethical principles, but basically how to interact with the patients and how to take care, how to manage their timing, all those things. And the question is how we can teach the ethical principles for 250 students in a large.
Okay, so let us take up these 4 questions. Maybe we can, you can combine them together, and we can start with Nancy, then Supriya, and then Ameer. Yeah.
How do we manage in a situation where India is suffering from acute faculty shortage, brain drain, and capacity building of staff? So the maximum National Medical Council has done is to encourage faculty to undergo online ethics training, which is NIE sponsored, free of cost, and online research methodology course free. Other than that, in such a large scale with this variety of different types of institutes, it's so challenging how from a systems point of view capacity build these faculty. And we have foreign medical graduates coming into the system, and then we have our own government as well as private. So one of the things that I would strongly suggest is in-person ethics training is not going to work. That's not going to be scalable. Even online, we can have some unique methods, teaching methods to case-based discussions, reflections, to capacity build the staff on different ethical principles in clinical practice as well as medical ethics. Definitely, because there is a shortage in terms of the quality of the faculty as well. So coming to sir's question, of course I am also guilty, sir, of what you have told. We are talking about global north, global south. Inside India also we have upper caste and lower caste, and we are utilizing our privileges to enter into the homes. So I want to share an experience in which we went to a house, and then there were demigods in the house, and then the students just barged in. And then the family was so upset, and that because the students didn't realize that it is a worship room. They never seen a demigod in their life. So I was very embarrassed and guilty of that. And then it was a day of shame for me as well. I felt very guilty that why am I doing this? I'm talking about global north and global south. I'm doing the same in the community. But we are still finding solutions. We are all guilty of this. We cannot enter gated communities, and we are not capturing their lived experiences or other things as well. So we are working on it, sir. I think the solution is that involve the community as much as possible, listen to them, and give dignity, respect to the dignity that they are having in all our approaches. Like the experience that I shared, we broke the dignity. So we have to protect and take measures to prevent that. Ma'am's question is very valid. We have medical colleges and institutes where 250 students are sitting in the lecture hall. One of the measures that I have taken is, I ask, engage, even with 250 we have engaging. Now AI is there, gamification techniques are there, new methods are there on how to engage. We have different softwares like Slido, in which students can use the cell phone inside the class. So when I come to the class and tell them that you are encouraged to chat, you are encouraged to use phone, but I make the rules here, then they are so curious. Why? What? Where is the QR code? What should I do? And then they chat among themselves, even if it's a class of 250. And then the activities like privilege walk, power walk, in which we show the privileges. I ask 5 volunteers from the 250, stand on the stage and demonstrate the walk there and ask opinions from the others. It works almost the same as a closed group. It's almost the same we can achieve. And evaluation is a challenge. When we write essays and then faculty are not there to do the evaluation, it's a challenge. But teaching, we can address.
Thank you so much. I think I'm just picking up across all this. One of the things which I understand, ethics education cannot be just one course or a unit or a module. I mean, I am teaching in University of Sydney. I mean, I've taught even in India. The idea of ethics education as something soft skills, or like the idea of only a communication skill, something, I think it's fundamentally wrong. I think it's very disservice, right, for the larger community and also for the students. It should be embedded across all. I mean, medical racism, as Jacob also was talking about, is the way we perceive, the certain idea of a patient or a certain idea of a target population, whether it's a health policy or programs or even at the clinic level, right? So we need to think about, it's a practice, but it should be embedded across all whatever we are engaging with. And the larger theme, which I think is about, I think your point of the way we think about privilege, I think the space, very often ethics education is filled with privilege and people who, it's unearned privilege which we have. And we always think as people who are there, these people who are there are always don't have agency. And I think it's something which we need to work on in whether it's a research or it's a community engagement at our policy level at every stages, right? And for that, I mean, again, I think I shouldn't say it's my kind of go-to is like, how do we practice reflexivity? And it's really tough to practice reflexivity when the institutionally and structurally we have been, the norms are completely based on the dominant caste value, hierarchy value. I mean, all gender, all the kind of intersectional, factors which plays in. So, I mean, I'm really, I just wanted to make it a point at this moment as we are discussing that bioethics as a professional discipline is something which is very difficult, or like more than I find it very strange for countries like India, or even for Australia. I would ask, like, what is this profession for? Because it should be part of every profession in many ways, ethics education or ethics in itself, right? We practice. Now, the other question for me is like, in the current global climate where there is, people use very, very abstract ways of polycrisis or ways of telling like we are having, actually, bioethicists are the classic, the way the dominant discourse is, we are silent about genocide. We are silent about, even within India, the privileges which we have. Privileged don't talk or won't want to talk about Dalit and Bahujan communities are people's marginalization, right? So then the question for me is like, whenever we talk about ethics education, somehow it's very sanitized. So I just wanted to make sure for faculty or for students or community workers, stop sanitizing the conversation on ethics, right? Something which I just wanted to reflect on.
I just wanted to say this, like, your opinion, whatever you said is actually reflect, when I reflect, like, am I doing ethical practices as a community health practitioner? That's the biggest issue. So the point is like, when I go to a village or wherever, a community setting, if I try to mobilize the people, most of the community members who comes for the meeting is the women. Men doesn't come. And they either go to taskmark, whatever. They're just simply sitting somewhere else. But see, the point is, it's a kind of a burdening the women more and more. So I need a people to come for my meeting to discuss whatever situation is there. And the men doesn't come, but we are discussing the health status of that community. So the burden is for them, and maybe like it's easy for me to kind of convince the women to come for the meeting rather than convincing men. So that's a kind of bias within myself. I'm working actually. And the village health participation committee, if you look into that, 80% of the members are women. So why? So it's a kind of it's not a gender disparity. The problem is like men doesn't want to give their time or taking effort to improve their health status, so that we are burdening the women. So this is kind of a privilege not only the caste haves and have-nots, but within the community also who doesn't have. Within this also, like whom we are targeting and whom we are kind of convincing, whom we are taking as a kind of advantage of on this to work for the change. That's the. I'm coming. So it's relating that. Correct. exactly, it's relating to that. And for me, if I reflect, like, no, each of this community, each of the circle, each of the group has to reflect upon. And that, no, am I doing it to kind of no ethical work? The point is like, there is nobody to kind of look after, kind of look up, like, no, are you behaving ethically, or I am behaving ethically? I don't think so. For example, in the exercise which we are doing in Tamil Nadu government is doing now for the last 4 years is a health assembly concept, where the government themselves are calling the people and asking them to say, like, no, what the need they have in the village. But the problem is, like, who's using this platform? Who has the knowledge? The doctors and the nurses within the system doesn't know that, like, where is the lacuna. So they use this platform and raising their voices, means like putting their needs. But the community doesn't know, like, no, what is the need is actually, what the government can offer to them. Without this knowledge, they are just simply sitting like, no, I need chair, I need doctor. No, that doesn't give a proper picture. So the informed opinion, an informed kind of, opinion from the people is the right kind of, way to address the need of the community. But that is not happening. So what I'm saying is, like, so each of these platforms, each of these circles has to think it over. When it's come to community, the Panchayat president will take a dominant role. See, he or she will say, like, no, I need a chair in my office, or I need a building in sub-center. But really, there will be problem of differently abled, access to differently abled people to medical center. That he may not put up. So for me, as I reflect, like, each of these group has to reflect what is the ethical dilemmas.
Okay, thank you for these more reflective answers. I think we are running short of time, and we can have one more question. So one question will lead to the second one. So you can have two questions. Yes, yeah.
I am representing ICEE Bioethics Unit. I heard all the gaps and perhaps the reflections on what each one had based on their community engagement. I'm here to give an afterthought to it in terms of what we can do. As you said, per discipline, there's an ethical education class, or perhaps there is, you want to put ethics in everything. That's a great idea. But why don't we start it at a very grassroots level, where even if you get an application form at the hospital to meet a doctor, or even if you write a paper, in any discipline, why don't you bring in, like, the ethical part of it and break it, embedded in our day-to-day healthcare practices, or even in the ethical education or medical education. Very often we see, if it's an ophthalmology class or a gynae class, we just stick to that particular topic. Why don't we embed ethics in every discipline? And most of our textbooks don't do that, we stick to the basic core science. So I think that's my reflection on it. So just a thought.
Okay, Prafulla, yes.
Just another reflection on that. Lot of these things come as your protocol and SOP that I was talking to Jacob. I mean, Supriya wouldn't disagree with me when I say ethics is very subjective and contextual, and then how can you put it in a framework is my concern. It's the biggest task actually to put ethics in a framework. It's very subjective, it's very contextual. Even when you talk about communities are so heterogeneous, so different. So, okay, yeah.
I think.
No, I just want to close this and hand it over to you. So I think we might have many more questions. In the afternoon, we have a session here at 2:45, answering maybe some of the Gayatri's questions. When there is big group, how do you manage and embedding ethical sensitivity in different ways? So basically, we are discussing today morning session and the afternoon session linked to what is the practice of ethics. So we have agreed that it can't be only be taught, and should not be only be taught to the students alone who are powerless in the in the scholarship hierarchy, but it also everybody has to be taught. And secondly, not only taught, we have to practice ethics, and we need more and more techniques which are not in the classroom. That is what we are discussing. I think this session of SOCHARA connects to Azim Premji University session in the afternoon. So those of you who are interested, we can have a better continued discussion there as well. So thank you, and I hand over to the organizer.
Thank you. I think Dr. Ann and They made my work easy by concluding. As you mentioned, my conclusion was we have to embed in our own. If I'm a teacher, it should start with me to practice ethics. If I'm a driver of a cab, I should follow ethical principles and I should practice ethics. If I'm a watchman, I should be ethical in my profession, in my dealing with my family. It should start with us. What I believe is that it will have a ripple effect. And whole system is doing, whole country is corrupt, whole this thing, the institution is corrupt. Let me also join with them. Even if I'm alone, if we stand apart, if we start practicing, definitely, if not immediate result, we'll be able to see its result in the longer run. At least my children will learn. My father was talking truth. My father was practicing integrity. And then the generations will follow. So I'm not preaching, but I just wanted to say small steps will help us to be ethical, and also whatever we are saying, education, it not be in a university. It can start from our homes, from wherever we are engaged with. It was wonderful, it was productive, and I believe that I have some points to take from this discussion. I believe that all of you have 1 or 2 points where you can take it from the session. The entire purpose is achieved, and I believe that we will be able to be ethical in our endeavors. Of course, Community Health Learning Program and Masters in Public Health, which we have collaborated with MLCU, we have a module on ethics. Different community health workers from different part of the country, they join our courses. There we have a module where we teach and also encourage them to participate. So in that same way, I think wherever we are, most of you who are seated here have some interest towards this, and you want to ensure that there is something done. Maybe you can take it, as I mentioned, further in the workplaces or the research places that we are in. Thank you.
I'd like to invite Prafulla Saligram. She's the Secretary Coordinator at SOCHARA to hand over these mementos on our behalf as well as on behalf of St. John's. Firstly, to Prahlad. Maybe we'll go in order. Jacob Dahlke. Thank you, Jacob. Ameer. Dr. Nancy. Supriya. Yeah. And to our chairs as well, Edward. And here to Alfred. Yeah, yes. Thank you very much. Thank you everyone for joining our session. We have a few posters on our work from SOCHARA. Feel free to go through them. And I think lunch will be happening at the main hall. Thank you. Thank you, Ed.